Hello, welcome again. Today we'll talk on Meckel's diverticulum. To start from anatomy of the formation of Meckel's diverticulum, the omphalomesenteric duct connects the yolk sac to the gut in a developing embryo, and this provides nutrition until the placenta is established. Then once the placenta is established, between the 5th and the 7th week of gestation, the duct or omphalomesenteric duct attenuates and separates from the intestine. Meckel's diverticulum is the most common congenital anomaly of the GI tract. It occurs in 2 to 3% of all infantis, and it's caused by the incomplete obliteration of the omphalomesenteric duct that is expected to occur during the first 7th week of gestation. So, it is due to incomplete obliteration of omphalomesenteric duct during the 7th week of gestation. It is a persistent omphalomesenteric duct, patent omphalomesenteric duct. Meckel's diverticulum has been conventionally referred by the rule of two, which explains the classic presentation of the congenital anomaly. Those are, Meckel's diverticulums are found in approximately 2% of general population. It's usually located 2 feet proximal to the ileocecal valve. It is approximately 2 inches in length, and it contains two types of ectopic tissue, mainly gastric and pancreatic tissue, and generally present before the age of 2, and it's found twice in males than in females. Also intra-abdominal in location, a rare presentation of Meckel's diverticulum is entrapment in an inguinal, umbilical, or femoral hernia, which is called letter hernia. Regarding clinical manifestation, majority of Meckel's diverticulum are clinically silent or asymptomatic. Symptoms of Meckel's diverticulum, if they are symptomatic, usually arise in the first or second year of life. The majority of symptomatic Meckel's diverticulum are lined by ectopic mucosa, including an acid-secreting mucosa that causes intermittent, painless rectal bleeding by ulceration of the adjacent normal ileal mucosa. This ectopic mucosa is most commonly of gastric origin, but can also be pancreatic, jejunal, or combination of the tissue. So the most common manifestations are asymptomatic, but if they are symptomatic, the most common symptoms is intermittent, painless rectal bleeding. Bleeding can cause significant anemia, but it's usually self-limited. This is because of contraction of splenic vessels as the patient becomes hypovolemic, and sometimes the bleeding might be scanty, and they may present with melonic stools. Less often, a Meckel diverticulum is associated with partial or complete bowel obstruction. The most common mechanism of obstruction occurs when the diverticulum acts as a lead point of intussusception. So it can be a leading point for intussusception. A Meckel diverticulum occasionally becomes inflamed and manifests similar to acute appendicitis. We call at this time diverticulitis. And this diverticulitis or inflammation of Meckel's diverticulum can lead to perforation and peritonitis. Regarding the diagnosis of Meckel's diverticulum, including other omphalomesenteric duct, depends on the clinical presentation. If an infant or child presents with significant painless rectal bleeding, the presence of a Meckel diverticulum should be suspected, because Meckel's diverticulum accounts for more than 50% of all lower GI bleed in children younger than 2 years of age. Confirmation of Meckel diverticulum is a little difficult because routine investigations such as plain abdominal radiographs are of no value, and the routine barium studies rarely fill the diverticulum. The most sensitive study is a Meckel radionuclide scan. Other methods of detection include abdominal CT scan, and sometimes exploratory laparoscopy is necessary. In patients who present with intestinal obstruction or a picture of appendicitis with omphalomesenteric duct remanences, the diagnosis is rarely made before surgery. So exploratory laparoscopy is necessary to diagnose sometimes. When we came to the treatment of symptomatic Meckel diverticulum is always surgical excision, either laparoscopic or open procedure. There is significant debate regarding the proper management of asymptomatic Meckel diverticulum, whether excision or observation is appropriate if it is accidentally diagnosed. However, the risk of serious complication does seem to exceed the operative risk in children younger than 8 years of age. So, a lot of scholars recommend surgical excision if the age of a child is less than 8 years, because a serious complication might happen, which overweights the operative risk. Thank you for watching.